So hi med scholars, in today's videos we're going to be discussing the Klumpke'S paralysis. Remember, we've completed brachial plexus and S paralysis. Do well to watch that. So still on nerve injuries affecting the brachial plexus. Let's start with an introduction. So the Klumpke'S paralysis was first described appropriately by an American-born French neuroanatomist, Augusta Klumpke. So it was first described by Augusta Klumpke. So it is a lower trunk nerve injury. It's a lower trunk nerve injury of the brachial plexus. So it's a lower trunk nerve injury of the brachial plexus. What are the nerve roots involved? So the nerve roots involved is simply the nerve roots that form the lower trunk. And what are they? So the C8 nerve roots and the T1 nerve roots, they are primarily involved. There could be involvement of other nerve roots based on the extent of the injury, okay? C7 could be affected, C6 could be affected based on the extent of the injury. And what is the primary etiology, or the cause, or the mechanism by which this occurs? What's the primary etiology or the cause of Klumpke'S paralysis? Well, there's simply a simple word to use for that. And guess what that word is? Hyperabduction. So the primary cause is hyperabduction. Hyperabduction of the arm. The arm is simply the sub-region of the upper extremity that extends from the shoulder to the elbow. So when there's hyperabduction of the arm, okay, the lower trunk of the brachial plexus is stretched and is susceptible to injury. And if this injury occurs, guess what you have? Klumpke'S paralysis. Alright, so what are the various conditions that can have hyperabduction of the arm? And they include the following. So number one, when there's a sudden upward pull of the arm, sudden upward pull of the arm. That's one scenario which this can occur. Another scenario is when there is also a sudden pull of the arm resulting to hyperabduction of the arm during child delivery. Okay, so during child delivery, there could be sudden pull of the arm. So there is a pull of the arm and there is hyperabduction of the arm. So when there's a pull of the arm, there's hyperabduction of the arm, there's increase in the angle. There's increase in the angle between the arm and the chest, and the chest wall, and the lateral aspect of the chest wall. So this increase in angle, okay, shows that there's every possibility for the lower trunk to be affected, since the lower trunk is going to be stretched. Alright, so that is what results to Klumpke'S paralysis. There's paralysis in this topic because these are nerves, and nerves innervate muscles. And when muscles lose their innervation by way of injury, okay, a form of functional denervation, what does that call? It's going to result to various forms of paralysis. And for this topic, it is called the Klumpke'S paralysis, affectation of the lower trunk of the brachial plexus. All right. So, what are the manifestations, or what is the clinical features? What are the various clinical features of Klumpke'S paralysis? Okay, so the various clinical features can be understood if we have an idea of the muscles affected. So if C8 and T1 nerve roots are affected, what are the muscles affected? We should look at the medial cord of the brachial plexus, because the medial cord of the brachial plexus usually contains the C8 and the T1 nerve roots as contributory, okay, and it goes down to supply these muscles. What are these muscles? The ulnar nerve is the main continuation of the medial cord of the brachial plexus. So when you get the innervation of the ulnar nerve, then you have a good standpoint to begin with. So the muscle we are going to have that is affected, all the intrinsic muscles of the hand, both the palmar and the dorsal interossi and the lumbricals will be affected, okay? The lumbricals, especially the medial two lumbricals, will be affected, right? Because the lateral two lumbricals is actually supplied by the medial nerve, okay? So the intrinsic muscles will be affected. So there will be lots of fine movement. So some flexors of the wrist, some, I did not say all, some flexors of the wrists and forearm will be affected. So those flexors that will receive innervation from the C8 nerve root and the T1 nerve root are going to be affected. All right. So the clinical features include, we have claw hand. This claw hand is a partial claw hand. It's a form of partial claw hand. So there will be hyperextension of the metacarpophalangeal joint, okay, of the medial two digits, and flexion at the interphalangeal joint of the medial two digits. So you are going to have claw hand. This claw hand is ulnar claw hand or partial claw hand. So number 2, there will be loss of sensation. So loss of sensation along the ulnar border or the medial border of the arm and forearm. Loss of sensation over the medial border of the arm and the forearm. Why is it so? It's because we have these nerves that actually emerge from the medial cord of the brachial plexus. And it's called the medial cutaneous nerve of arm or brachial, and the medial cutaneous nerve of the forearm or antebrachial. So they are going to supply the skin. They provide cutaneous innervation to the skin over the medial aspect of the arm and the forearm. So if there is affectation of the lower trunk of the brachial plexus, that cutaneous innervation will be compromised. And how will it manifest? As loss of sensation. All right. So we also have what is called the Horner syndrome. Horner syndrome could be a clinical feature. Horner syndrome. So, what is Horner syndrome? So, Horner syndrome is a constellation of symptoms that was first described, okay, by a Swiss ophthalmologist. And this Swiss ophthalmologist is known as Friedrich Horner. So Friedrich Horner, a Swiss ophthalmologist, described this syndrome. How does this occur? Usually, if there is affectation of T1 in Klumpke'S paralysis, okay, some sympathetic outflow to the orbit will be affected. This sympathetic outflow to the orbit, okay, they usually take some sort of origin at the level of T1. They are postganglionic sympathetic fibers. In fact, postganglionic pupillomotor fibers. And they carry sympathetic innervation to the dilator pupillae muscles, okay, or the iris dilator, as well as to the levator palpebrae superioris, the involuntary part of levator palpebrae superioris. And guess what that muscle is called? So that's why it's called the Muller's muscles. So the Muller's muscle that was named in honor of Heinrich Müller, okay, is actually the involuntary part of the levator palpebrae superioris, and it actually receives sympathetic innervation. So the sympathetic outflow from the level of T1 that goes to the orbit can get affected if there's affectation of the T1 nerve root. So most times when there is injury to the lower trunk of the brachial plexus, affecting T1, also proximal to T1, you're going to have Horner syndrome. And what are the various characteristics of Horner syndrome? So in Horner syndrome, the following is seen. So there will be ptosis. In ptosis, there is drooping of the eyelid. So this partial drooping of the eyelid is due to paralysis of the involuntary part of levator palpebrae superioris. Okay, So what sometimes is called the superior tarsal muscle or the Mueller's muscle. So very important for you to take note of that. So there'll be drooping of the eyelid, and it's a form of a partial drooping. Then another clinical feature that you're going to find in Horner syndrome is meiosis. So meiosis is a form of constriction of the pupil. Why is the pupillary constrictor dominating? The pupillary constrictor is dominating simply because the dilator of the pupil, or the iris dilator, or dilator pupillae, okay, is paralyzed. So if the dilator pupillae is paralyzed, the pupil cannot dilate. Rather, there will be an unopposed activity of the action of the sphincter pupillae. So what you are going to have is pupillary constriction, and guess the clinical term for that is called meiosis. All right. So there's also enophthalmos. So enophthalmos is the form of outward protrusion or affectation of the orbit. And what causes that enophthalmos? It is simply caused by decrease in the fat part of the orbit. So there's decrease in the fat part of the orbit. This theory that the enophthalmos in Horner syndrome is caused by a decrease in the fat part of the orbit and the form of a trophic effect was actually postulated by von Michel. So that was the von Michel's explanation, okay, to this. So that is what simply happens there. All right. So that's enophthalmos. Which other clinical feature is seen in Horner syndrome? In Horner syndrome, there could be loss of ciliospinal reflex, especially if the injury occurs proximal to the T1. There could be loss of ciliospinal reflex. Okay? So there could be loss of ciliospinal reflex if the injury occurs proximal to T1. Alright. So another name for Horner syndrome is oculosympathetic paralysis. Horner syndrome is also described as oculosympathetic paralysis. So oculosympathetic paralysis. So there's an ocular sympathetic outflow, okay, in the form of postganglionic sympathetic fibers from this superior cervical ganglion, and they exit and they travel along with the internal carotid artery, gets to the cavernous sinus, they join the abducens nerve, and they get distributed to the orbit. Now, so a very perfect understanding of the Horner syndrome, okay, requires you to understand what is called the trineuron arc. So there's what's called the trineuron arc, which actually explains the sympathetic innervation of the orbit. So the first order neurons are coming from the posterolateral aspect of the hypothalamus, and they descend uncrossed. They move through the midbrain to the pons, okay, and exit down to the medulla, and they move down to the interval between the C8 and the T1. So between the C8 and the T1, they are going to terminate, okay, by synapsing with a nuclei. And that nuclei is called the intermediomedial nucleus. So the intermediomedial nucleus, okay, in the lateral cell column of the spinal cord, that is where these fibers go down to, okay. And this region, that region is known as the ciliospinal center of Borg. So it's called the ciliospinal center of Borg. The ciliospinal center of Borg. Okay, so because Ludwig Julius Borg was the first to describe this phenomenon, so it's called the ciliospinal center of Borg. All right, so we've been able to discuss Klumpke'S paralysis, the various causes, and the affectation of nerves and the clinical manifestations of Klumpke'S paralysis. One more thing before we go. Whenever Klumpke'S paralysis is associated with iris heterochromia, okay, or heterochromia iridis, there's a unique name for that, and it is called the von Passo syndrome. So von Passo syndrome is Horner syndrome plus iris heterochromia or heterochromia iridis. Thank you very much for watching this video. Do subscribe to get more information from MEDSCHOLARS. Thank you.